But you're all here today to have your level 3 adult and child safeguarding update. This is a local update, so we do talk about what's going on in Suffolk, so hopefully it'll be really relevant to you, and those of you in North East Essex, a lot of it will be relevant to you as well. We'll just have slightly different referral processes, which we don't have slides on, but we can get that information over to you after the session. So we very much do this as a joint session because we want you to think across the lifespan. So we want you to think about the child behind the adult and the adult behind the child. Think about who's in the home. If you're worried about something, you know, who does that have an impact on? Do you need to tell anybody about it? Do you need to act on it? So very much looking at that kind of holistic approach, really. So the first thing to say is safeguarding can be really triggering for some people. It's quite a sensitive subject to have to listen to. We're really aware of that. If you do feel that you need to take some time out and, you know, just take some time for yourself, if it's getting a bit too much, that's absolutely fine with us. You don't need to tell us you're doing that. Equally as well, if you want to speak to us at the end of the session, we can stay on the call if you feel that you need to sort of have a bit of a debrief about anything. Obviously, we do talk about real situations, and many of you on the call today may have had some personal experience of some of these things, so we're very aware of that. So yeah, please look after yourself and put yourselves first throughout the training. So the aim of, or the aims of this session is, obviously you probably all have had some kind of level of safeguarding training before, but what we want you to have is that understanding of currently what's going on locally. We do, like I said, we do talk about some real cases. We'll talk about sort of some national learning and how we can put that into practice. We want you to feel really confident in what you need to do if you have a concern, so where you seek advice, the processes that you have to go through, and like we said about how to make those referrals. So in Suffolk we have a MASH, so a multi-agency safeguarding hub. That's not the same in North East Essex, but obviously the sort of the processes are similar. It's just a different way of making sure that referral is sent in. And we want you, like Tabitha said, we want you to be really open with us, be interactive. It's much more interesting if you ask questions as we go along, if you share examples, share cases that you think might be interesting. It's far more exciting and interesting for you than just having to sit and listen to us for 2 hours. So please make sure that you interact. Because I'm sharing my screen, I can't see the chat or any hands up or anything like that, but Tabitha will monitor that. So please do just shout at us if as and when you need to, really. Tabitha, do you want to do a bit about this one?
Yeah, so we recognise for all of us that, you know, work pressures are never great. So, you know, safeguarding, though, unfortunately, is one of those things that isn't something you can say work pressure's diminished. It will be the one that unfortunately comes back to bite us on the bum. So both Joe and I respectively sit on the Suffolk Safeguarding Partnership, who are the people that hold the serious adult reviews or the child safeguarding partnership reviews. And these occur when there's been a death of either an adult or a child, and they feel that there's a safeguarding component. So, you know, it's about learning. However, you know, it's really important to put safeguarding at the front. It goes across every single work stream. It depends on really, you know, the access you have to being able to check that your concerns are being met. All right, or you know, you want to bounce an idea off. So that's one of the reasons why we asked about the supervision. So, you know, it's about saying, do you have somebody to go to? Or if you've had, just as Joe said on slide 2, you know, if something's triggered you or you need to discuss something, supervision is where you take it. OK, and both Joe and I are trained to do that. So, you know, it's really, really important that we recognise not just for your patients, but also for yourself and your colleagues about safeguarding and its importance. But you know, we acknowledge that work pressures are there. It is a busy time for all of us. However, safeguarding still trumps it. Back to you, Joe.
And what I forgot to say at the beginning is we are happy to send you a copy of these slides so you don't have to sit and write copious notes. And also some of these slides you'll notice, like this one, has a quick YouTube link at the bottom. So this particular one, they're all only about 4 or 5 minutes long, but this particular one talks about the different roles in primary care and where that fits with safeguarding. So we always say it doesn't matter really whether you're a GP, whether you're a receptionist, whether you're the cleaner that comes into the waiting room and observes something, you know, with a patient in a waiting room. It doesn't matter what your role is. If you see or hear something, or you're told something, or you're worried about something, you do have a duty to act on that, and you are never alone when you do that. So make sure that you know where you can go to for support and advice. Some of that we'll cover today, but obviously some of that will be down to your individual practices as well, all of which have safeguarding leads in them. So yeah, so just make sure that when you get the slides, you spend a little bit of time just looking at these quick videos. Okay, so what we're going to do now is look at kind of what the picture is in Suffolk at the moment. So these statistics are from February this year. To be honest, the actual numbers don't change a huge amount. On the left-hand side there, you've got obviously the children that are currently open to child protection plans. Now, some of you may know that if a child is on a child protection plan, that means that it's the highest level of concern. That means we're saying that there is evidence that the child or the children in the home are at risk of significant harm. And to have a child on a child protection plan, there is a case conference that is convened, led by social care, but everybody is invited that's involved with that particular child and family. Everybody has to be sharing information as part of a report into conference, and then everybody has a say in what they think the result needs to be. So if at the end of that conference they say, yes, we have evidence that the children are at risk of significant harm, they'll be on a child protection plan under one of these 4 categories. So emotional abuse, neglect, physical abuse and sexual abuse. Now you'll see the comparison with the adult statistics on the right hand side. There's obviously a lot more categories with adult safeguarding, but one of the common ones obviously across both is neglect. So you'll see on with the children's one, neglect is by far the biggest category in Suffolk. It's also the same nationally. So over 50% of child protection plans are because of neglect. And I think when most people think about safeguarding, particularly with children and vulnerable adults, you're thinking about those cases that maybe hit the headlines. So if you think about baby P, it's going to be the broken bones, the bruises, those really nasty, horrific physical abuse cases that we all hear about that shock us all. But actually, in reality, the majority of those cases are due to neglect or emotional abuse. So what we usually do at this point, if it's okay with you, is if we ask you to have a think and pop in the chat what you think you might see or hear or maybe read in records that might make you think either a child or a vulnerable adult is being neglected. So what do you think about? Anything that you can think of. It can be a word, it can be a sentence, anything you like. If you want to share a case, you're very welcome to do that as well. So we'll just give you a few minutes just to have a think and pop it into the chat. And remember that because of how common these cases are, you're going to probably be seeing them through primary care every single day almost.
So we've got we've got non-attendance at school, missing appointments, withdrawn appearance, malnourished, hungry, dirty, unseasonal clothing, avoiding going to the doctors, appearance a few times, unkept, withdrawn, stomach issues, poor attendance, withdrawn, change in behaviour. So not attending school. So the only thing I think, insecure, self-loathing, parents answering questions, reluctant to speak up in front of relative caregiver, changes in behaviour, no eye contact. I think can we just pick up though, perhaps when we talk about unclean, etc. So it's just really important to say about standards of uncleanliness and what that means. So because we're talking about under 18s at this point, so we're going to talk about adults in a minute, just think about, what that means for different age groups, because it's probably totally acceptable for a 4 and a 5-year-old to have dirt under their fingernails, thinking about their child development, etc. like that. But would you expect a newborn baby to have that? So, just thinking about what that means and unpicking it for yourselves in your heads. When you're thinking about poor attendance at schools, etc., obviously for a well child, that isn't acceptable. But think about, the unwell child, you know, that is acceptable. There are support mechanisms for that, but just have that, just think about them and unpick them, and just try and think about, because child development is interesting and that overlays everything that Jo has just said. And some of what you have written is also totally applicable to adults as well. But yeah.
Okay, brilliant. Yeah, so you picked up some really good stuff there, some of which we'll follow up with maybe over the next few slides, but certainly things like when children or vulnerable adults are not brought to appointments. So primary care, we have guidance for primary care in Suffolk on when children or vulnerable adults are not brought. We try and steer away now from saying that they did not attend, because it's not their fault that they didn't attend. They were not brought, and for whatever reason that appointment wasn't able to be prioritised for them on that day. That's down to their carers actions, so we need to be thinking about that. But yeah, as Tabitha said, different levels of neglect, and neglect can be lots of little things that build up over time. So it's really important that you record everything clearly in the record, because it may not meet a threshold for you to actually act on a particular occasion, but say 6 months later, if it's continuing to go on and it might be escalating, might be getting worse, you then need to be able to look back at what you've written and what other professionals have written as well, and decide, actually, is this now a much bigger picture than it started with? Do we now need to do something about it? The next biggest category is emotional abuse. So if you think about a child living in a home with domestic abuse, which again we'll talk about later on, they are victims, that they are now known to be victims of domestic abuse in their own right, just for being exposed to it. So they will be suffering from a degree of emotional abuse. Emotional abuse is really difficult to pick up, actually, unless you spend a reasonable amount of time with a young person, or you know them very well. So because it does tend to be changes of behaviour over time, that's why teaching staff are really well placed to pick up on emotional abuse. And then the last two categories, so sexual abuse, is obviously much rarer, thankfully, but it does happen. The thing to remember about sexual abuse with children is that quite often children either don't know that they're victims themselves and think that what's happening to them is normal, or they've been threatened to not speak up about it. So they very rarely disclose that they're a victim of sexual abuse, and it's up to us as professionals to help them with that, and to encourage them to disclose if they feel that they are able to, but to look for signs that they may be sexually abused. So things like bruising in unusual places, frequent urine infections. Think about, young teenage girls coming in and wanting the morning after pill, not wanting their parents to know that they've been in, potentially signs that they're being controlled in some way. All of that kind of stuff could also be not just a sign of sexual abuse, but sexual exploitation as well. And then the last category there, the smallest one, is physical abuse, and this is much more black and white. So these are the bruises in unusual places, the broken bones, the injuries that are inflicted upon them, whether it's burns, bite marks, anything like that at all. We have a non-mobile baby policy, which we'll talk about a bit later on, but if a baby is non-mobile, they should not be able to injure themselves accidentally, and we have to act on that in the right way. So we'll specifically talk about that policy a little bit later on. But over to Tabitha just for the adult stuff, if there's anything extra to add for that, really.
Thank you, Jo. So if we just use some of the words that you've just given down the side, thinking about, somebody said poor attendance at schools, etc. So, you might think over 18s, but, think about those young people who are either on apprenticeships or going to university, their attendance. The coming to GPs, obviously over the age of 18, you're legally an adult, which means that you're able to make your own decisions. But we do know that, when we think about, in particular, young boys and their brain development, we know that that can take some time for some individuals to mature. This becomes particularly important when we look at the children who have been looked after, or in old terminology, fostered, and they move out of the care system and they become care leavers. So we know, for example, that those individuals may not have had the structure around them to understand why they need to go to GPs, especially if they've got, let's say, a diagnosis of diabetes and they need that management. So, it's always about and I'm going to introduce a phrase that Jo and I will talk a lot about through this: professional curiosity. So think beyond what you're hearing. You know, what are the implications for that? What could be the rationale? You know, and helping somebody migrate through that. When we think about also non-attendance, let's think about the very different end of the age group or care system where people have carers or they're unable to get there because of frailty. You know, it's is there a reason for that? You know, when the carer comes in with somebody who might have a disability, is that carer on the telephone, or are they actively engaged with you? Are they participating? Do they look like they've got their you know, individuals' best issues prominently? Somebody wrote stomach issues. We also know that perhaps with those individuals where they're unable to articulate, and they might have a profound learning disability, that they will also describe things that we might associate with children. You know, picking up about appearances and what people said, you know, thinking again about the, you know, the very elderly and the cost of living crisis. You know, people are being able to afford food. You know, so it's really, really important that you give that wide thought about it, especially when you're looking at people who might have a deterioration. So, you know, you might start working with them and they're presenting really, really well. And then over the time you get to see them, you realise that that's becoming a bit more withdrawn. If any of you do home visiting, oh, that says so much, a home visit. Really, really says a lot. But again, when you're describing that, you've got to be explicit. So, you know, state what it looks like. Don't just say it looked disgusting. You need to say, as I walked over the threshold, my feet stuck to the carpet. The carpet was sticky, and therefore, as I walked, I found it hard to move. The smell as I opened the front, or as I entered the property, was overpowering, and it had a strong odor of cat pee, rotting vegetables, whatever it is. Be absolutely explicit. You need to build that picture for whoever is going to be reading that, especially if you have a concern about safeguarding. Okay. Just like Jo, with all of those pie chart sections, if you're abusing somebody, you're always emotionally abusing them. It literally, whether or not it's about power and control, or if it's purely just psychological abuse, the abuse of a individual always includes emotional abuse. So, you know, I won't dwell on that, but we have these figures, as I say, they're very current and we get them every month. So I'll move back to Jo. Thank you.
Okay. So what we're going to do now, unless there's any questions, I'll just stop there just in case there's any questions. No, okay. We've created a fictional family. Okay, so obviously this is worst case.
Zoe's got a hand up, Jo.
Oh yeah, sorry, Zoe.
Hello. If
Hello.
you're talking, Zoe, we can't hear you.
Oh, there you go.
I'm always doing that on mute. I just noticed, sorry, on the pie chart, 5% none, not recorded. What's that representing as such? So this 5% here, not recorded, none.
So that doesn't mean that it's not a good way that the data comes out. Okay, Zoe, well spotted. Thank you very much. Sometimes it just means that actually the threshold wasn't met,
Right.
but they needed signposting somewhere else.
Okay.
So the 5 is, and work still would have happened. So when somebody does a referral, there's always still a search that needs to happen or a contact made. So it doesn't mean that anything didn't happen. It's just that it didn't meet the categorization. Because actually what's not down there, and Jo and I've always mentioned this before, is something called prevent, which we will talk about later. When you're concerned about people being at risk of radicalisation. So, you know, it could be that they've gone into the prevent pathway, which isn't caught on these figures here under a section 42. But we will talk about that later. No, that's a pleasure. Well spotted. Perfect. And thank you.
That is, at least you're paying attention.
Yes, definitely.
Okay, so yes, so we've created this fictional family just as an example of when you have a patient, your patient could be the dad, but actually what you need to do is look at who's in that family and what their issues are and how that could impact. So this is the Evans family. So they live in a 3-bedroom terraced house in a local street. So Lisa is the mum, she works part-time. Carl has a full-time job but is low paid. There's no concerns about parental drug and alcohol misuse, but there are concerns that both parents suffer from depression. We know that money is tight, but the family are reasonably connected within the community. They take advantage of various youth clubs and drop-in community centres and early help support, but have not been seen as regularly in the last 9 to 12 months. So some of you may know, I don't know if you've heard of early help, but early help is the support that's at the lowest level. So it's not social care involvement. We have an early help team in Suffolk that you can refer people to if they have children, to sort of get that support for things like housing issues, support with budgeting. I don't know, there might be a mum with a mental health problem that's struggling, you know, and it's not tipped into safeguarding, but the idea with early help is that you put that support into to prevent it escalating. All right. So that's just to introduce the family. Now, the next slide, now we're going to find out a little bit more about each family member. Have a think about what worries you about this situation. So Lisa is mum to all 3 children. We know she's a smoker. There's some low mood and she feels disconnected from her family. She works at the local primary school, and we know that she's a previous victim of domestic abuse. And those of you that have access to records, the domestic abuse notifications from the police do get added to the record. So even if you know, it's historic from a few years ago, you will still be able to see that they've been a previous victim. So then we've got dad. So dad, father is youngest. Sorry, he's the father to the youngest 2 children and stepfather to Benji. He's had a mixed employment history, current job in a warehouse. He's previously a looked after child, so he spent time in foster care himself and requires some support at school. Then we've got Benji. So Benji's the eldest of 3 children. He's 16 years old, increasingly in trouble with within the community and police. He's not had any contact with his father for many years. He was 5 when his mum married Carl, and we also have just found out that his 15-year-old girlfriend is pregnant. Then we've got Hope, who's 11. She's not in school because she's being bullied. She's regularly self-harming and spending large amounts of time online. And then lastly, we have Blake, who's 8. We don't know much about Blake. We know that he's rarely attended the GP surgery and has not attended for all his immunisations. So if you can either put your hand up and speak, or you can pop it into the chat. What worries you about this particular situation? Is there any thing that's jumping out at you that thinks that there's some real vulnerabilities here?
Oh, Lucy's got a hand up. Go on, Lucy. If you're talking, you're on mute. No? You again?
I'm off.
You're okay, off you go, Lucy.
Go for it.
They're waving my hand. I think for me, Hope self-harming is a real concern. I would want to know why he's self-harming, because self-harming can get worse over time, and spending large amounts of time online is also a concern because we don't know who he's interacting with, and that could open a huge can of worms, couldn't it?
Yeah, absolutely. Yeah. So I don't want to put you on the spot, but that obviously with things like spending lots of amount of time online and not being in school, quite often young people are then at risk of exploitation. They're not having that social interaction that with their peers that they would normally have in school, so they often look for it elsewhere. So that's, like, you're exactly right, they're going to be doing things like potentially, you know, getting into chat rooms, playing games online that they can chat with other people with, and then because of their vulnerability they could be at risk of being kind of groomed and exploited for various different reasons. Yeah.
So I went through all of this with a family member and her 2 children. Literally from start to finish, advocating for her. So I've been through the system. So it is really difficult, isn't it?
Absolutely. Yeah, definitely. So yeah, you're right to pick her out definitely as one to be worried about there. Absolutely. Thank you, Lucy.
And we've got also there's very little known about Blake. Well done. We always put that one in. We did that one deliberately because we wanted to see if people pick that one. Yeah, where is he spending his time? Benji's being in trouble with the police and his 15-year-old girlfriend being pregnant. His first 5 years witnessing domestic abuse. Yeah. And then where is Hope if she isn't in school? Yeah. Anything about the adults? Got any worries about the adults? Yeah, we've got a lot about domestic abuse.
Go for it, Lucy, unless that's an old hand.
No, it's a new one. So I noticed with the mother that you've written smoker, but you haven't written it for any of the others. I'm not sure what bearing that has. However, in my experience, smoker could also mean smoking cannabis, which can be detrimental for somebody's mental health, and may or may not lead to other drug use. But because she's got disconnected from the family and history of low mood, she may all suffer from depression and anxiety. And if she's smoking, that's not good for you, is it? And if she's smoking weed, then that can obviously exacerbate her low mood and her disconnection from the family.
Yeah, absolutely brilliant. Bang on. And one of you's also just put down that Carl was a looked after child before, and that impact upon him. So yes, this is what we I can't come back to you. I said the phrase on the last slide. Professional curiosity. Yeah, that's it. Yeah. Well done. Yeah, exactly. Just what it means, those impacts. So, for example, we do know that where children are brought up in a household where at least one parent smokes, there's an increased likelihood of having asthma, and actually what that has as an impact upon their health and moving forward. So there's really, really loads of bits and pieces there that can be picked out without it even meeting the safeguarding threshold. There's a family there that needs support. Have they got the right sort of support? Does it just need a little help like you do with social prescribers? We're not all linked into everything, are we? So yeah, absolutely. No, excellent.
Also, just to highlight the fact that mum was a previous victim of domestic abuse, we do know research shows that if you've been a victim of domestic abuse, you're at higher risk of becoming a victim again. So you're more vulnerable to kind of getting into that cycle of being with or attracting an abusive partner and being in that situation. So that is something to take into consideration. And also the fact that dad requires some support at school. So does he have some learning needs? Does he lack understanding and maybe need some additional support for that kind of stuff as well? So lots of things to think about. But yeah, that's good. So the next part of the story then, just to go further on, we're looking at Benji a little bit closer. So since the birth of baby Gracie, Benji has struggled to manage his temper and behaviour. So we know that social services are involved with him. He's open to a child in need plan. So a child in need plan is the level below a child protection plan. So it is social care and there is a social worker involved and there's a plan in place, but we don't have evidence that he is at risk of significant harm. Okay, so it's that level below. We also know he's no longer in education as well. So Shannon, his girlfriend, so she's 15, as we know, she lives with her parents. They're very supportive. We know that her mum had her when she was under 18, so she understands her situation. Benji is allowed to stay over to help support Gracie, but on occasions her parents have asked him to leave because of his behaviour. And we also know that Shannon receives support from the Family Nurse Partnership Programme. I don't know if any of you have heard of the Family Nurse Partnership, but just in case you haven't, that is a kind of intensive version of the health visiting service, and it's available for young mums or young parents. So you get a lot more visiting. It starts much earlier on during the antenatal period, and they have that kind of closer relationship with their family nurse that really does work closely with them for things like one-to-one antenatal classes, intensive visiting in the early weeks and that kind of stuff. So then we've got Gracie. So she's 3 months old. She's doing well. This particular case is open to early help due to concerns about dad, so Benji. So again, there's no evidence of significant harm, no safeguarding, but it's to just prevent, you know, it escalating. So Shannon noted a lump to her leg while changing her nappy 2 days ago. She was seen by the paramedic at the surgery. So what would you be concerned about if you think in front of you is a 3-month-old baby with a lump to her leg, and knowing the history that you know, what would you be worried about?
Oh, Gracie is non-mobile.
Yeah, there's a little bit of a hint at the bottom. We should have,
Yeah,
we should have
get
put,
it.
yeah, we should have put those links on a different page, really. But she's non-mobile, and as I said, she will not be able to injure herself accidentally. So you have to follow that non-mobile baby policy. So any bruise or mark or unexplained injury to a non-mobile baby has to be discussed with the on-call paediatrician at the hospital, and 9 times out of 10, or 9.999 times out of 10, they have to be seen at the hospital for a full paediatric medical assessment, which will involve a full skeletal survey, so full x-rays, CT scan quite often, to look at if there's any other injuries, what the injuries actually are, can we determine whether there was any kind of medical cause for those, or are we suggesting maybe it was a non-accidental injury. So the links to those pathways are there for you to look at. Just to put it into context, we've had 2 cases in the last, well, we have frequent non-accidental injury cases. I went to a meeting about one this morning, but 2 that really stick in my mind were both seen by GPs in Suffolk, and both attended their surgery because of a concern about either a lump to either the leg or the arm, and actually the babies themselves presented with no other issues at all, no crying, feeding well, sleeping well, no other issues. And when both of them were referred into hospital, they were found to have multiple other fractures. So it just goes to show what is presented to you may not be the full picture, and you have to follow that policy to be able to, you know, to know more, really.
I think could I just say, somebody has really, and I think that's very sensible, has Shannon caused the injury?
Yes, that's, you know, that's, yeah, you have to be open-minded, absolutely. So absolutely. In these situations, so the meeting I went to this morning was a baby that had got a non-accidental or potential non-accidental injury. They've had to look at who has had care of that child. So we're looking at mum, dad, and maternal grandmother. They will all have to be, you know, questioned, and look at what, you know, where that baby is safe to be discharged from hospital too, because actually we don't have evidence of who's actually caused those injuries. So it's lots of safety planning is done, very careful consideration and planning is put in place for these particular cases.
Yeah, and I think the other things are that I know somebody's mentioned Benji's temper as well. Lucy, I did see your hand go up, so we're coming back to you. But you know, there was really another good comment here about was she aware but failed to protect? You know, you know, and just as, I mean, the only other thing I'm going to add is remember that the non-mobile baby policy is not just about full-term babies with no disabilities. You know, you need to consider this, and the whole reason it was being written was because, again, following a case review many years ago about a baby. It wasn't a baby, it was I think it was a 1-year-old, if not older, who had profound disabilities and couldn't move, and the bruising that child had. So, you know, it's about thinking about it slightly wider. So Lucy, is this what you were going to say about saying she'd be contacting the paramedic to see what was done and if a safeguarding had already been raised? Is that what you were going to say? I could see you nodding, and I saw you say yes. I could see your picture. So yeah. I mean, you know, absolutely. If not, as Joe said earlier, all of the surgeries have safeguarding leads, GP safeguarding leads. They should be your first point of call. Okay. If there is a deputy in the surgery because the lead is not there, then that's fine. Okay. And if either the deputy and the lead are not available, then that's where you probably either want to be thinking about MASH and or Joe and I. Okay. So that's what the system is there for. But yeah.
Okay. All right, we're going to move into the adult world now. So over to you, Tabitha.
So please don't think that our cases that we made are trite, but Joe and I are trying to encapsulate as many possibilities within a very, very short time frame. So hopefully both of these cases will resonate with you. We have a carer, physically well but struggling with her own emotional health, and her partner who has sadly got a degenerative disorder. They've got intervention going in, health intervention, the district nurses, but we've written the word cluttered there. There should be a clue. Have you got any worries or concerns? Feel free either put your hand up or put the chat down. Yeah. Home visit possible to assess. Yeah. Wheelchair bound. Is he able to move around the house? Yeah. Wires jack withdrawn. Yeah. Pulled. Yeah. Carers. Yeah. Neglect. Carer not coping. Absolutely. Hoarding. Hey, well done. That's lovely. Anybody get the Guardian newspaper? You'll find there's a big article on hoarding in it today. Support, should they be in a residential home? Dementia worsening, mental health of ED, neglect of some type, friends, family support, ability to mobilise the home, set support. Last time the GP saw the patient. Yep, all very good. So we're basically, just like our last family, we're feeling a little bit uncomfortable with things, aren't we? I'd be concerned about the lack of intervention by, I think that's probably adult and community services. Is that what you meant by ACAC? It's adult and community services, ACS. So yeah, that's what we're worried about. Okay, so Jo, I think she got the next slide.
Okay. Yeah. So what we're going to look at now is how to capture the voices of patients, and we get this in quite a lot of case reviews, whether it's an adult or a child, where the most common learning actually from all case reviews is poor information sharing, a lack of professional curiosity, and a complete lack of the fact that you haven't heard the voices of the child or the adult in the case. So we know that for many reasons you may not actually be able to hear and capture their voice. It might be that they're too young, they may have communication issues, they may just not want to open up to you, which is absolutely fine. So you're going to have to go on what is in front of you to be able to tell you what their life is really like. So there's a few things on the left hand side there, things that you can look at. We talked already when we talked about neglect, about things like hygiene, their clothing, how they present, how they behave, all of those kind of things. Think about what that tells you. We often talk in safeguarding about having that gut feeling, and I know many of you will know exactly what we mean by that. So you have that gut feeling that something's not quite right, but you can't quite put your finger on it, but actually it will be enough for you to then think, I need to be a bit more curious, I need to maybe ask a few extra questions, I need to take some time to look at these records a little bit more, I actually might need to pick up the phone and speak to another professional that's already involved with this particular case. So go on what's in front of you. On the right hand side of this slide, you can see some of the situations where the voice is not heard, and why that might be. So particularly with children, we quite often have parents that will do all the talking for them and they won't let them have any say at all. And, we need to get children used to being asked questions directly. As long as they're old enough and able to answer them, we should be speaking to them directly and then speaking to the parents, because they are the ones that, should be able to have their say. So a parent taking over and controlling a situation would be a red flag. Too much focus on practical matters, so too much focus on things like housing issues, getting a child into education, all of which are really important, but actually have we looked at what things mean to that child? Have we asked them? And if it's a vulnerable adult, have we asked them? Exactly the same situation. And as it says at the bottom there, think transition. So if you've got a vulnerable child, they will, if you do nothing, will turn into a vulnerable adult. So you need to be looking at that transition from children's services into adult services as they get into 18. At 18, concern doesn't just stop and risk doesn't just stop, it will continue and it will change. So we need to think about that process as well, and how vulnerable that kind of 15, 16, 17-year-old age group are as they move into adulthood. And again, this slide has got a little YouTube clip video here. This is mainly focused on children, but exactly the same for adults. You know, that they want to be heard, they want to be listened to, they want to be talked to. So the more we do that, the better. And very similarly with adults. Do you want to talk a bit about this, Tabitha?
Yeah, so just as Joe said, this is the document that guides adult social care. It's making safeguarding personal. It's a little bit of a weighty one, but it does help with making sure that you have put the voice of the adult at the centre of the safeguarding referral. Okay, and it's really quite a big thing. So even if you have somebody, just as Joe has spoken about with children, who is either unable to articulate or doesn't have capacity, you know, you can, you know, it helps, it just helps frame that safeguarding referral. And, you know, by making reference to it as well, it's demonstrated that you've really, because if you've made reference to it, you've thought about the voice of that individual in front of you. So just like Joe said, you know, if you have a parent speaking too much, what if you have a carer speaking too much? You know, is it appropriate talking? How is that parent, you know, sometimes, you know, you can see it, carers make reference to who they're talking about, they turn to them, they look at them, you know, there you know that they're trying to put the best forward for that individual. Whereas if they're just holding perhaps eye contact with you and they're not acknowledging the person next door to them, then perhaps they haven't thought about them. So, you know, really, really good. There's many links there that we put. The one to Working Together for Safeguarding Children, that's just about to be reevaluated. We're all giving our comments on that, as well as the Was Not Heard YouTube clip, which is only a few minutes long, isn't it, Joe?
Yes, it is. Yes. Yeah. Okay, so the next two slides then are some case reviews. So we'll start with the adult case reviews, and like we said, these are local to Suffolk. So I'll pass you to Tabitha for these two.
Okay, so thanks, Joe. So if I start with the second one, Nigel. So basically all the case reviews, be they children or adult, you can look at on the Suffolk Safeguarding Partnership. And for Essex, we haven't forgotten you, Essex colleagues. There is the equivalent, it's the Essex Safeguarding Board, I'm sure it's called. And if you go on there,
children's board and an adult board, don't they? I think
that's right. Yeah. So they have. If you go on their websites, you can look at the adult version. They're the Essex versions. Okay. So we realise these are Suffolk versions, but the principle is still the same. So Nigel was learning disability adult, and yes, they're both COVID linked. We do have new ones coming up the whole time. And it was really unfortunate because he was isolated. So if we go back to both of the case studies we presented, we mentioned, you know, isolation, and people not aware. He wasn't even registered on the GP system as having a learning disability. And all of you must know about your LD annual health checks, your LD registers that the surgeries hold. And yes, it's about having a diagnosis of LD and or autism, but it's still, you know, at least it gives that, unfortunately, whether we like it or not, a definer. But yeah, so Nigel was a really quite an interesting one from the point of primary care, really interesting one. Abby was what we call a learning review, and they happen for children as much as they do for adults. And Abby starved herself to death. Quite an old-fashioned thing to do now, but she absolutely starved herself to death. And again, the act of her not eating was also slightly overlooked. So when you think about young people, everybody's all over anorexia and eating disorders. They forget that that is as applicable to anybody at a point in their age where they can manage their food. So yeah, please, if you're interested, we also have the domestic homicide reviews on there. And we'll talk about those a bit later. Joe, back to you. I think your children next.
Thank you. Yeah, so we're going to move on to the children's ones. So yeah, like we said, these are real cases. So you know, if you do need to talk to us afterwards, or you want to just take some time out, you're very welcome to do that. We're going to start with the first one, which went for a thematic review, because we had 3 babies, 2 of which sadly passed away, 1 of which suffered a life-changing injury. But there was quite a lot of sort of common themes with their background, so it went forward for a thematic review. So 2 of these babies sadly passed away due to unsafe sleeping practices. So 1 fell asleep with mum on the sofa, and there was some evidence that she'd had some alcohol the night before, and another baby sadly passed away having shared a bed with mum as well. And both those situations, actually, they weren't staying in their usual sort of accommodation, so there was some sort of unstable housing. They were sort of visiting friends and family. So we need to make sure really that the safe sleeping advice that we give is consistent, that we don't just give leaflets, that if any of you are going to be giving this sort of advice, we follow the Lullaby Trust guidance. They do provide leaflets, but we actually do need to be talking to parents about this, explaining why babies need to be put on their back to sleep, that they're not near a radiator or an open window, that you don't share a bed with them unless it's done particularly safely, but it's safer not to. That things like alcohol and drug use does massively increase the risk to babies in these situations. So the more that we do that, so if you think about midwives giving that advice, health visitors, practice nurses, GPs, if you're giving it as well, then actually we're covering a much sort of wider area really. The other child who survived and is now doing fantastically in care suffered a few broken bones, and the similarity with that was that Dad himself was known to social care. I think at least one of the other parents had been in care themselves. So if you go back to our fictional family with Dad, that does increase the risk when they then have their own children. So lots of learning from the thematic review. You can, as Tabitha said, you can read this online if you wanted to, but we do need to think about how we offer support, particularly to young parents, particularly when it's their first baby. So giving that health advice, but really explaining to them about it, and really supporting them so that they feel like they've got somewhere to go, and that they can talk to somebody. And then the second review that we've had recently is the case of Annika, who was a 17-year-old. She had autism and she was mute as well, so she had a severe learning disability. She was seen actually for her annual LD health check not long before she sadly passed away. She lived with her mum, and there was some concern about neglect within the home, but it wasn't necessarily totally understood until, unfortunately, after she died, when a home visit was completed and they saw the home environment and how unhygienic and how big an impact that would have had on her life. So she was unwell. She actually had an issue with her PEG feeding tube, and the GP had done a referral into the hospital to get it checked and replaced, but they hadn't had any contact from the hospital yet, and she became unwell and actually sadly passed away due to her PEG feeding tube receding into her stomach, which then resulted in that infection and sadly her losing her life. So there is some learning to come from that, in that mum had contacted the GP surgery for advice because she was vomiting, but then when they called her back, she never answered the phone, and they repeatedly called her back and she never responded to that. So if there's any evidence that maybe we've got a parent that maybe has some difficulties understanding, or maybe not prioritising a child's needs.
Jo,
like
we've got a hand up. Sorry to interrupt. We have a hand up.
Carry on.
Go on. Lucy, do you want to ask your question?
It's not a question. It's just I was just thinking about what you said about the surgery repeatedly trying to call mum.
Yeah.
From my point of view, I mean, I don't have any clinical qualifications, but why did somebody not go and see her?
Well, you could. That is kind of the obvious thing to think about, but I suppose what you have to think about is if you, because they get a huge amount of calls, I guess, every day, don't they, surgeries? And you know, they do have situations where they don't then get answers when they call back, and I suppose they can't visit everybody. So hindsight is a wonderful thing. It's easy, I guess, for us to say, yes, of course somebody should have gone and knocked on the door, but I guess they can't do that just due to workload. They can't do that with every patient. However, she was known to be vulnerable, and she was known to already have some issues with her feeding tube. So, you know, whether they could have done anything else or not, they tried at various different times of the day, calling. It could be that you've got a mum that then actually thought, well, she's better now, so I don't need to, you know, I don't need to speak to anyone. I don't know. But yeah, absolutely. We have to think about when we need to do something differently and think outside the box a little bit.
We do sometimes, it's been discussed, but we do sometimes get tasks about not safeguarding but welfare checks. So we would go out and literally door knock on someone's door to see how they are and if they need anything. And yeah, I've done quite a few of those where if I can't get hold of somebody, I'll just go around there.
Yeah, and that's amazing if you can do that. Oh, yeah, absolutely, and that's exactly what needed to happen.
That there's lots of clinicians out there that can't do that or don't have the time to do that, but yeah,
absolutely.
Thank you.
And the other thing was when she had her annual LD health check, the appointment had, or the referral, sorry, had already gone into the hospital for her PEG tube assessment, but that wasn't necessarily looked at again for that annual health check, and that was a slight missed opportunity for the surgery to contact the hospital and chase up that referral and say, we've still got an issue, when is it going to be looked at? So yeah, there's a few bits and pieces there that we can always learn from, really. Okay, I think if we do a couple more slides and then we'll stop for a break, is that all right with everyone? Are you all right to do this one, Tabitha?
Yeah, I was going to say, everybody, if Joe and I ever ask for a big thing, just either put thumbs up or something in the and then we know we're roughly on track. I'm sure many of you know about the Mental Capacity Act assessment. Came in 2005. However, it's about doing it sensibly, clearly, and with the patient, and where needs be with their relatives. Every single GP system, whether it's System 1 or EMIS Web, has templates. Okay. If you have never done an MCA and feel uncomfortable about doing it, then make sure you're finding somebody else in that surgery. Okay, really, really, really important. The last bit at the bottom, which is slightly hidden by the rainbow banner, is executive functioning. Okay, so that's the bit that often is overlooked. So it is about, can somebody do what you're asking them to do? So if we take the example of, you know, Abby, and can you feed, because that was one of the outcomes from Abby, the adult learning review. It was asked, could she feed herself? And she went, yes. And nobody said, well, can you show me? What would you do? Which would help understand whether or not she could do it. And a bit later on, a clinician did go round and see her and was able to get her to eat a packet of crisps and drink a glass of water. However, obviously that then wasn't followed up, and that was just a temporary element. So it is about, if you're going to do an MCA, it is, you know, obviously you should always assume that somebody has capacity to start with. And if you're in any doubt, and say if you've never done one, seek advice, absolutely seek advice. It might be worth, if you feel unsure about doing mental capacity act assessments, that might be something else for training for another session. They are, at its basis, if done well and followed through, it is quite simple. It's just that people usually don't do them and then record them badly. But if you are unfamiliar with them, look at the templates in the surgeries you're attached to. Please, Sophie's there. So technically, yes, you can do an MCA if you're not clinical. Okay, because carers can do it, residential home care staff do it, lots of people do it. Okay, So, but if you need to do training, I would absolutely urge you to let Sophie know, and we can arrange for that to happen. If you've got clinical staff around who are able to do it, then get them to do it, that by all means. But the MCA is about a wide range of people doing it. The respect form on there is about, you know, your wishes or patient's wishes about when they're coming to the end of life. Deprivation of liberties is the Dole's phrase there. And that's about when somebody has restrictions on their ability to live as the rest of us do. Lasting power of attorney is the LPA, and court-appointed deputies. They really need to be, you really need to know about if they're there. So if somebody says to you, oh, I've got LPA, there will be a form. There will be a form that they should be able to find for you that is validated by the Office of the Public Guardians. If they are unable to provide a form, then they do not have an LPA. Okay, I am absolutely explicit about that. The same for court-appointed deputies. Court-appointed deputies tend to usually be social workers. Okay, so, you know, again, they will be able to provide you with that evidence. LPA, thank you, Michelle. LPA, so lasting power of attorneys exist for health and finance. Everybody gets their knickers in a twist about having finance, but in the grand scheme of things, it's your health and well-being that is the most important thing, because again, it's about who's going to look after you if your capacity diminishes. So it's a really good one to have conversations with when people are at the first stage of diagnosis. So whether or not it's dementia, Parkinson's, things like that, it's a really, really good conversation, because it can happen still before they have before they're unable to contribute to it. Angela.
Hi, can you hear me all right?
Yes, Dawn. Yeah.
Yeah, okay. I just wanted to dip in there about court-appointed deputies, because I am for my son, and there's court-appointed deputies for health and finance and for welfare. So you have to have two different pieces of paper for those, and to actually get court-appointed deputyship now for welfare is extremely few and far between. It is just not happening. So just wanted everyone to be more aware of that, really.
And Angela, thank you, because I do genuinely, Joe vouch for this, normally talk about court-appointed deputies for parents who have children who don't have capacity. And it is one of the things. But Angela, please, if you are happy, my understanding is that if you're applying for it yourself, you have to pay for it privately. Is that still the case?
So it costs quite a lot to get the paperwork through, and every year there comes through a charge from the office of the Public Guardian to sustain that as well. You can offset that against the individual's personal situation. So if they're on benefits, you might be able to, not have to pay that charge. But yes, when it comes down to actually applying in the first instance, it's quite a substantial outlay. Yeah.
And I'm not asking you to say any more, but certainly I know, I think it was about £4,000, and that's just for one. So, and that's without any other legal costs that might be added to that. So, court-appointed deputies are really, really important to be aware of. And, as I say, ever so humbly, Angela, you're actually the first person that I've ever spoken to who's ever had one, but I knew that they existed.
Oh, really?
Yeah. So that just goes to show, but I do know.
Not a lot of people know about court-appointed deputyships. Lots of people know about power of attorney, but obviously for people who lack mental capacity, it is court-appointed deputyships. But not a lot of people realise that. So
that's right, and it's usually something, say, you apply for. So for example, when you have a young person who's 16, if that's the case, then you need to be, certainly people need to be highlighting that to parents or carers if they're going to keep the individual, that they can apply for that. But especially if you've got to save money.
Yeah, if they're going into residential or into a care environment, if you want to be able to have a handle on their care or finances, yes, that's certainly the case.
Yeah, Angela, I can't thank you enough for being brave enough to say that. That's really, really important.
No problem.
Thank you, thank you.
Okay.
Oh, literally, you are the first
No
person.
worries.
I don't know. I've been in this. I've been in the CCG ICB since 2015, and I've always known it existed. But you are literally the first parent I've ever spoken to. So that says a lot, doesn't it?
Oh wow. Well, you do get reviews by the Office of the Public Guardian, and they will come out and do visits to court-appointed deputies on a regular basis to check. So it is quite well monitored.
Bless you, bless you, David.
All right,
thank you, Angela.
thanks.
Thank you, David.
Jumping on the bandwagon. My partner is also a court-appointed deputy as well. So there's two in the room. There's two in the room. So there you go.
Honestly, I tell you, that speaks volumes, doesn't it? Thank you so much. I really do appreciate the two of you saying that, because it's something I've had up on slides that I've done for years and years, and it's just like, thank you. So my suggestion is perhaps you also might want to say that to the surgeries you support, just so to make them aware. But yeah, no, thank you. And the last thing on there is about advocates. So, use of advocates. If you think somebody would benefit from having an advocate, they don't have to have a diminished capacity. It could be to do with speech, it could be to do with extreme anxiety, things like that. That's what Power is there to do. Okay, they will support you on whether or not that individual does need an advocate or not, but they are another one that you need to be really, really mindful of. Thank you, Jo. Sorry.
Absolutely. And just to add, it can advocates can also be helpful if you've got a young person, so 16 plus, when there's concerns that parents are not acting in the best interest of that child. So an advocate can be a really good thing to do, to put in place if you've got that kind of situation as well. One more slide really quickly, and then we'll stop for a break. So this is just to make you think about this. I mean, obviously we do this training for GPs and practice nurses as well. So it's about not being too quick to book telephone appointments. If you think actually by looking at the record, if they're, like we talked earlier about young parents that maybe need that increased level of support, if there's a safeguarding history, if there's a mental health concern, anything that will make you think actually this needs to be a face-to-face contact. And obviously some of you do home visits, which is amazing. So think about what could be missed if it is just a telephone call. What more can you gain by actually having that contact face to face? We've talked already about being professionally curious. We probably don't need to go on about that again. And also about information sharing as well. So this is about looking at who else is working with this particular patient. Do you need to link in with them? Do you need to share information? Be proactive, get in there before you absolutely have to. Start sharing information early, and do it with the patient's knowledge. So you can say, oh, it'd actually be really handy if I spoke to that person. Are you happy for me to give them a ring? And you can really build up those networks and actually work together to support that patient much better as well. Obviously, when it comes to safeguarding, we have to be able to share information. You don't need consent to do that. If it's reached that particular threshold, then it is clearly high risk safeguarding, then you have a duty to share information, and there's lots of guidance around that as well. So those of you that are in Essex, the next few slides, I'm sorry, are probably not going to be as relevant to you because we do have different processes in Suffolk. But like we said, if you look on the Essex Safeguarding Children's Board and the Essex Safeguarding Adult Board websites, you should be able to find their processes on there. But for Suffolk, those of you in Suffolk, we have Customer First, which is the 0808 number there. So that is for any emergencies where you feel an adult or a child is at immediate risk of harm. If you're ringing that number, you potentially might have to ring the police as well. That's also the number that you would ring if it's out of hours. So our MASH, which is the Multi-Agency Safeguarding Hub, is open Monday to Friday, 9 till 5. So if you have a concern out of those hours, you can also ring Customer First and log it that way. If you're unsure if a referral is needed, you can call the MASH professional consultation line, obviously like we said, between 9 to 5 Monday to Friday, which is the 0345 number there, and that is where you can discuss with a MASH professional, discuss the case, and then between you can decide whether a referral is needed. There's 3 options when you call that line. So if you press 1 if you've got a concern about a child, 2 if you've got a concern about an adult, and if you wait and press number 3, that is to a health professional. So you'll get straight through to the MASH health team, which is quite often easier when you're talking about a case to talk health professional to health professional. You kind of have that mutual understanding. We've talked already about you discussing things with your safeguarding leads in your practices. Failing all of that, you can contact us as well for advice. So our mobile numbers are there. We're also very easily contactable by email. If we're in meetings, to be honest, email is usually a bit easier. And the Suffolk Safeguarding Partnership website is there for you as well, which I'll show you a picture of in a second. So that is where the online portal is. And really importantly, record everything that you do, any discussions you have, clearly in the records. Tabitha, do you want to do a little bit about the thresholds?
Oh, yes, thank you. You're very happy. So on the left, you have the adult one, and on the right, you have the children's one. Again, just as Joe said, if you go onto the Suffolk Safeguarding Partnership website, you can see both of these. Probably go back to your surgeries and can you just check that they've got copies? Because Joe and I both sent them out little copies, didn't we, Joe?
We did.
So they should have them. It again helps frame what your concerns are and what your worries are. They work slightly differently. But at least it helps you say, is this something to be worried about, or is it something not to be worried about? And you need to make reference to it if you're going to do a safeguarding referral. So what I'm going to suggest to you is that if you're doing a safeguarding referral, you do it with a clinician, and that just because they're a clinician doesn't mean to say that they've got good practice. So you can say to them, these 2 people, they gave us a little talk, and this is what they say we have to use. It will help frame what you're going to do, and it will also help you when you're discussing it with the individual. Joe and I will talk about this later, but there is absolutely one referral you do without discussing it with the patient, and you heard me correctly. Okay, if you are concerned that you are working with somebody and they are being radicalized or at risk of radicalization, then you would do a referral to prevent without notifying the patient. Okay, I am not wrong in what I've said. We are covered in law, and this is very, very clear about counter-terrorism. Okay, and it is explicit in both of those documents. Okay, so if you think that you have somebody that is at risk of being radicalized and you want to talk about it, you email either Joe or I. Okay, and either of us respond, be it adult or children. Okay, that's the only thing that you can do without discussing with or making attempts to discuss with an individual.
There is also just that one other one where which we'll talk about later on, but it's fabricated illness. So if you have a case of a child that you think the parents are, for whatever reason, inventing or inducing illness in their child, you would not tell them that you're making a referral, because that will increase the risk to that child. So that's another example, but we'll talk about that a little bit later.
Thank you.
So these are the 2 documents that you would use to just help with your referral, the wording of it really. And then on making the actual online referral, so the admin teams within each surgery has a Word document which actually is quite helpful to use as a template to complete, and then so first off you would complete that and then you would copy and paste it into the portal. And we only say that because the portal itself, the referral portal, does time out after 20 minutes of inactivity. So if you start it, get distracted by a phone call or something like that, go back and haven't saved it, it will have wiped everything. So usually, and it's much easier to do this, complete the Word document first, then log into the portal and then copy and paste it in your responses into each box. Just massively speeds up the process. So yeah, your admin teams within your surgery should have that Word document. So you're on the top right hand side here, you've got the Suffolk Safeguarding Partnership website. You can see the big red rectangle there. It says worried about someone, report it here. If you click on that, it will then ask you whether it's a child concern or an adult concern. Obviously, for the purposes of this, we click child because the picture underneath there is the Children and Young People's Portal, which is on the Suffolk County Council website. And then it will talk you through what you have to do. The first time you do a referral, you have to register your details, and you get sent an access code so that they know who you say you are, just for that extra security. So that does happen. The 2 links we've put on this particular page are the links for additional support when it's not safeguarding. So for an adult, if there's care and support needs, but not needing not needing safeguarding support, you would complete that portal. And again, when we talked about early help a bit earlier on for children and families, you would complete what is called a CAF referral, which is a common assessment framework, and that's the link for that one there. And now I'm going to give you a bit of a whistle-stop tour of what happens when it goes into the MASH. So again, apologies, this is Suffolk processes. But once your referral goes in, whether it's been phoned in through Customer First or whether it's gone in through the portal, it will come in. As we say, it goes to Customer First because that is the gateway into social care. The first thing they will do is they will look and see whether this case is already open to social care. If it is, it doesn't go into the MASH, it goes directly to the lead professional, so the social worker or the lead professional that's working with the case. So it's really important that you're aware of which ones are already open, because you don't have to do a new referral. You would simply pick up the phone and speak to that social worker directly and share your concerns. But if it's not open, it will go into the MASH. They will triage it. So a consultant social worker looks at it very quickly within a matter of minutes, and they RAG rate it depending on what level of risk they think is involved with that particular case. So if they rate it as red, they're saying it's really high risk. They need to gather all the information from all the different services and make a decision about what needs to happen next within 4 hours. If it's amber, it's 24 hours. And if it's green, it's 72 hours. And once they've RAG rated it, they decide which services they want information from. So you can see on the right hand side there, you've got all the different services that sit within the MASH. Obviously, most of the time they will get social care information and they'll get police information. They won't always get health, but quite a lot of the time they will have. And we have a MASH health team that has access to System 1 and EMIS Web as well. If it's a child referral, they will nearly always go to education if it's a school-aged child, so they'll be speaking to the school. They're basically just gathering all the information that they think will be necessary for them to be able to make a decision. Once all of that information is back, they then look at that and decide what the outcome needs to be. So if a case has come in as red and rated as red and it's saying is high risk, once they've gathered all that information in, it doesn't necessarily mean it stays at red. It actually could mean that by sharing that information, the risk has been reduced. You're then aware that things have been done and professionals are supporting that particular case. So it might result in no risk of significant harm, and actually maybe information and guidance given that if it's a child case, the parents might have been signposted to other support services, and there's no further action in the information guidance section really just means they've decided that there's no ongoing role for social care at this time. Equally, sometimes cases can come in and they can be rated as green, and then we can gather information from all the services, which actually increases the risk. So we may find out that there's a police history, there's domestic abuse incidents regularly, children aren't going to school, whatever it might be, and actually it then results in being rated as red at the other end. So we're needing to have strategy discussions in some situations where we're really concerned, a social worker or a police officer might have to go out and do a visit the same day to decide what needs to happen next. And sometimes with these cases, we'll say, actually, we do need some more information. We can't make a decision today. So a social work assessment is needed. And in those situations, a social worker would have 45 days then to complete a full assessment on that particular case to be able to then decide if there is an ongoing need for social work involvement or not. So a lot of stuff happens in the MASH. Cases only sit within the MASH for a few days at the most. They are then either closed or they leave the MASH and are sent to a local social care team to then continue to work with. So that's a bit of a whistle-stop tour of what happens in the MASH. Is there any questions about any of that? No. Okay. The outcomes of referrals do cut. If you're the referrer yourself, you will get the outcome directly to you. They obviously prioritise those high risk cases. So if it takes a week or two for you to get an outcome, that probably just means that you know, it's not seen as high risk and there wasn't necessarily any work ongoing that's needed to be done for that particular case. Signs of safety. Do you want to do this, Tabitha, or do you want me to?
Yeah, can I just
to
say,
share the love?
Oh, yeah, share the love. I'm just going to say thank you to Shirley for putting the link into the Essex. That's really brilliant.
Yeah, thank you
so much. All right, yourself and Tara have obviously responded to your colleagues in Essex conversation, and it's a really valid point that if Joe and I do this again, we will put in a couple of Essex slides. All right, we hear definitely. That and we acknowledge it. So thank you.
Yeah.
So Signs of Safety is a system that came over from Australia, and it's a way of, it initially started off for children and parents, but it's been used in the adult world as well. It's a way of explaining and supporting and demonstrating all of those words, what professionals think is going well, but also what might need to happen, and you know, in a really quite, not pictorial's not the right sense, but they do use pictures, but in a really if you ever sit in a child protection or a child in need meeting or a safeguarding meeting relating to adults, they usually put up big sticky things around the walls, and even if somebody can't read well, what you can see is the wealth of information being written underneath either of those three headings. It's really clear to everybody to understand. And for those of you who are familiar with rural Australia, you may know that the Indigenous community out there do have difficulties in accessing consistent education. So it's worked really well out there, and it's very simple. And both Joe and I used it when we were health visitors, and you know, it certainly generates a lot of conversation. Social workers do some pre-work before it, but it's actually something that you can use pretty well in any sphere of life. You know, perhaps you're in a team meeting that's not working very well, you know, well, what's not working well, what we're worried about, what needs to change, etc. But if you Google Signs of Safety, it will bring up loads of stuff for you. But it's that's quite succinct, because I realise we're at half three.
That's all right. I was just going to mention briefly about the scaling, so just so people understand about that. So at the end of whether it's a case conference or a child in need meeting, or if it's an adult case, professionals and the carers or parents involved are asked to scale where they think the level of risk is, with 10 being absolutely perfect, no need for support, and 0 being we're so worried if for example, if it's a child case, potentially those children need to be removed that day. So everybody's asked to scale and justify why they've chosen that particular scale, and they have to say what they need to see to be able to increase their scale next time. So the idea with it is that obviously parents, if it's a child case, can see exactly what people are worried about and why, and the level of concern, but most importantly, the score should be going up each time, not down or not moving. And if it's not increasing, then we're doing something wrong and something needs to change. So what has changed since the introduction of Signs of Safety is that social care are involved for much less time than they would have been before, because cases move forward and progress is made, because it's such a practical approach. People know what is expected of them to make those changes, so things move much quicker. Okay.
Yeah, Sophie was just talking about Signs of Safety training, and it turns out one of the colleagues on the call have done it. But yeah, both Joe and I did it. I remember it being
many years ago.
Yeah, full 5 days sitting in a classroom. I think it's less than that now. Hopefully.
Yeah.
Yeah.
So the next few slides are going to be about certain topics related to safeguarding. So to start with, domestic abuse. So This is a really big issue, as many of you will know. As it says here, it's very often unreported. We know that 1 in 5 children have experienced domestic abuse, which is a huge number. When you think of an average class of 30 children, that's a lot of children that will be exposed to domestic abuse. The most important message that we can get across to you today is that you routinely ask about domestic abuse, obviously only when it is safe to do so. If you think an individual is a victim of domestic abuse, their partner is sat with them, you're not going to maybe talk about that openly. But if it's safe to do so, you must absolutely ask them. And there's different ways that you can do that. Some of the examples here: do you feel scared at home? Do you feel controlled in any way? And making sure that it's clear that domestic abuse isn't just about the physical abuse. It's about being, it's about the emotional abuse. It's being verbally abusive. It's about being financially controlled. It's about not having the freedom to contact your friends and family, that kind of stuff. So it's really important that you ask, as it says here, respond, risk assess, refer, and then record. So the Anglia Care Trust domestic abuse hotline, and again, this is going to be, because this is a Suffolk presentation, I apologise, it is different in Essex, and we'll need to get that information over to you. I think we probably didn't realise there was going to be as many Essex professionals in the training today, so apologies for that, but we will get the information over to you. But the Anglia Care Trust hotline is a 24-hour helpline that is available in Suffolk. And if they're given that number, they will get local information, and things like safety planning can be done over the phone, that kind of thing. You have to remember that most people that are victims of domestic abuse, if you ask them about it, will say, "Oh no, I'm fine, everything's absolutely fine." But what you will realise is that when they're then ready to seek help and disclose that they're a victim, they will remember that you've said that, and they will come back to you and they will open up to you. So the more we ask, the more likely it is that they will one day come to you and say, actually, yes, I am, and I need your help now. Some of you may have heard of MARAC, which is the multi-agency forum where we discuss the high-risk cases of domestic abuse. So referrals can be made into MARAC if you feel, that actually a multi-agency response is needed. If it's high risk and, you think some safety planning needs to be done here at that higher level, then definitely do the MARAC referral. You have to do what's called a DASH risk assessment, which is a really simple tick box exercise that you can do with that particular patient. And remember, if you've got a case of domestic abuse and they've got children, even if they say, "Oh no, my partner's left me now, we're not together anymore," you still have to do a safeguarding referral, because those children potentially are still at risk. They may still be having contact with that individual, so you must do a safeguarding referral. The next slide is just some more sort of general signposting for different services and things like that. So obviously those of you in Essex can use the National Domestic Abuse Helpline, which is here as well. Many of these are national as well. Is there any questions about domestic abuse?
No, but there has been some chat in the chat. There we are. That's really awful of me. Chat in the chat. About Essex and what they do over there. So again, I'd like to say brilliant. Thank you very much. So I'm just going to highlight. So the conversation that held me up joining earlier this afternoon was I was taking a phone call from a health professional in Suffolk who was concerned about a 18-year-old who has previously been a looked after child and has got into a relationship with somebody who is 20 years older than them. And there are issues around emotional and mental health, and there has been bruising seen on the young person. And give them all their due, the surgery who have had contact with this young person have asked if there are any issues with domestic abuse, but it's just to highlight that it's active. It's not like Joe and I are having these fancy conversations. That was literally a phone call I took a couple of hours ago about it, and suggesting what next steps need to happen. So please do ask. If you don't feel comfortable to ask, are there any issues of domestic abuse, you can ask, do you feel safe at home? Do you feel safe when you're asleep? That's quite an interesting question. Some of you might have heard about the power and control wheel. These are really, really easy to use. The other name for them is Duluth, Duluth. And on one side, it talks about what is a safe, secure relationship. On the other side, it says what isn't. And they can be used with everybody. And even, I think if you go onto the Duluth website, they even do ones for if you're, you need easy read, is what I'm trying to stumble out. But they do them in a wide range of languages, and you can just print them off. I will put the website into the chat so you can have a look at that. But it's a really, really easy thing to use, and any of you can use that.
Amazing. Thank you very much. Okay, so another hot topic, and I mentioned it briefly already, but this sort of children, but also vulnerable adults with complex health needs and disabilities. So these are quite possibly likely to be the types of patients that you get involved with. So many of you years ago will probably remember hearing about the term Munchausen's or Munchausen's by proxy. That has now changed to be known as fabricated or induced illness, but we also now have the added term of perplexing presentations. So just to start with fabricated or induced illness, this is when we have evidence that for whatever reason a parent or carer actually wants to exaggerate or invent, or in extreme cases induce illness in their child for whatever reason. It can be for financial gain, for things like disability living allowance, for the attention. So they're kind of craving a diagnosis for their child for the attention that it gets them from other people, things like that. They may have a mental health issue themselves. We now have the added term of perplexing presentations, because sometimes we have cases that don't quite meet that threshold, but they don't quite add up. So we have parents sometimes just really exaggerating symptoms. We have parents that will Google what it means if a child is autistic. Some of the, I don't know, this is just an example, but some of the symptoms or some of the signs that you will see that may suggest your child should have a diagnosis of autism, and they literally will go in to see the surgery to say, this is what my child does. And quite often in these cases there's no evidence from any other services that there's any concern. So they'll report things like, my child has seizures or has vacant episodes, but that child is in nursery and the nursery has never seen it, but the parent reports that happens, or the parent reports that they vomit all night, but again the nursery or the school has never seen it. Quite often it's things like mobility issues that they report, and again not seen by anybody else. So this is one of the situations where I said you wouldn't be telling the parents that you're worried, and actually you would contact us in the designate team. We have a designated doctor for safeguarding children, Rachel Furley, who is really involved in a lot of these cases, and we work together with you to pull together a professionals meeting to share information, and then to decide as a group of health professionals, and often the school if they're involved as well. We will decide whether we need to get social care involved or not, or whether we can contain those anxieties within health services. And quite often it does start off with an anxious parent, but it can snowball from there. So if you have any of these cases that you think you might have, please get in touch with us and we can support you with that. The Safeguarding Partnership documentation is there. That link is there for you. It has a really clear policy to follow. We've also added a link here to a news article of a young person. So I'm pretty sure she was over 18. Tabitha, correct me if I'm wrong, but I'm sure she was over 18. And she reported certain symptoms. Yeah, because that's the other thing. If you have a child with fabricated or induced illness or perplexing presentation that you don't quite get to the bottom of, and it drags on and drifts on, then you end up with an adult, like in this case. So have a read of this news article. It's very interesting how this young person and her mum managed to completely pull the wool over people's eyes, raised a lot of money for trips abroad and things like that for her. Really interesting how these cases can happen, and they play one professional off against another. So the most important thing that we need to do is let them see that actually we're working together, and we're talking to each other, and we're not going to do endless onward referrals for different services and things just because they're not getting the answers that they want. Actually, we need to be looking at how we can contain that, really. And equally, when you've got a young person with disabilities, but also an adult as well, we know that they are 3.8 times more likely to be neglected and suffer abuse than their non-disabled peers. So please be aware of those really vulnerable groups, and think about, you know, they're less likely to be able to protect themselves. Quite often they have communication issues, so they're less likely to be able to disclose and speak up about what's happening to them. They often have mobility issues, so they're not going to be able to necessarily get away from that abuse. So really makes them hugely vulnerable. And like we mentioned already about the Suffolk Advocacy Service with these young people, if you've got evidence that the parents are not acting in their best interests, absolutely think about an advocate. We had a case of a 17-year-old boy with quite severe complex disabilities and health needs. The speech therapist had worked with him for many years, and it was very clear that it was not safe for him to be orally fed, that he should be fed via his feeding tube only. But his parents continued to orally feed him, and sadly he did pass away in the end. But that's clear evidence that the parents were not acting in his best interest and were not following advice. They said they were, but there was concerns that they absolutely were feeding him orally, you know, without professionals' knowledge. Moving and looking at transitional safeguarding. Tabitha, do you want to do this, or do you want me to?
Oh, I'm happy to. So it's not a new thing. It's been around for 10 years. Joe and I had to do a presentation on this, and we did a bit of research. The lead researcher on it is a lady called Dr. Des Holmes. So if you want to know more, and it is about preparing. There's another group you can look at if you're working with somebody that you think may need support about preparing for adulthood, and it's called Preparation for Adulthood. And it's called PFA. And it is about thinking about those young people. So especially your looked after children cohort, those with learning disabilities and or who might be categorised under the special educational needs and disabilities, you know, and supporting them with that move into adulthood, because nobody really explains to you lots of bits and pieces that might happen. So, for example, booking GP appointments. There's a really big one. How do you know when to book a GP appointment? Why should you book a GP appointment? By GP, by the way, I mean everybody on this phone call. Sorry, virtual phone call. I don't just mean GPs. I'm just using it as a grand term. But, you know, why should you? The importance of smear tests in women, the importance of annual health checks if you've got a learning disability and or autism. So there's a whole raft of things there that people need to be educated about that they may never have been educated about, either because they've been, you know, that's been a missed opportunity, or perhaps they just need it repeating to them again. So transitional safeguarding is a really big thing, especially now we have many services that are now going from 0 to 26. So, you know, you're thinking about children and adults within one service arrangement. And Joe has put the links there to the case of Adam and Annika, which we've both mentioned before. So, yeah, thank you.
Perfect, thank you. Moving on to look at another topic, so exploitation. I mentioned this already, and we talked about it when we talked about the family, that, you know, potentially there's a risk of exploitation there. This is a case review that you can read if you wish to. It's not a local case, but this is an example of a child that it wouldn't necessarily normally be the typical child that you would think would get caught up in these kind of things. So Jaden was actually doing really well in school. There was no history with him at all with others with social care. He got excluded from school for a period of time due to inappropriate social media posts, and during that time when he was out of school, he was obviously spending more time either online or outside the home. He was sort of targeted by a group and groomed, and then he got involved with things such as county lines, various other things like that, and sadly he lost his life in that process. So it's just a case review that we think is helpful to highlight, because we do need to be aware that it can happen to anybody. And another little YouTube clip here, again only 4 or 5 minutes long, by a police force elsewhere in the country. Really powerful, particularly if you are a parent to teenagers like I am. absolutely watch this, because it just shows you how you have to be looking at their behaviour and thinking about what that tells you about what's going on. They're not necessarily going to be actually speaking to you about what's going on, but does their behaviour say anything? Are they spending more time out of the home? Are they late home sometimes? Are they suddenly coming home with, you know, new trainers that they would have no access to money for normally? That kind of stuff. All of those things would be a red flag. So definitely, if you've got some time, just spend some time having a quick look at that. Then we've got the multi-agency forums that we've mentioned some of already. So this is really to say, yes, we're worried about all those things. Safeguarding is, you know, as we said at the beginning, a really horrible thing to have to talk about. There are lots of risks. There are lots of things going on in Suffolk, but there's also lots of positive things that are being done about those things. So I think we're really proud locally, and these things happen in Essex as well. It's exactly the same across Suffolk and Essex, that there are these multi-agency forums where everybody can come together to discuss the cases and jointly decide what needs to happen to protect those individuals. So MAPA is where we talk about the people that are at risk, seen to be a risk to the public. So it's quite often those individuals that are being released from prison. We would need to meet together as a multi-agency group to decide how that can be done safely, who needs to be informed, is there any special measures we need to put in place. Those of you, if you've got any patients that are open to MAPA, your surgery should be informed of that, because the probation officer that works with that individual should have completed a form to let you know that the case is open to MAPA. So if you see that in the notes, that's what that means. MARAC we've mentioned already briefly, but that is obviously the high risk cases of domestic abuse. We have MARAC meetings taking place every week across both Suffolk and Essex. And those of you that access children's records in particular, you might notice literally an addition that says case discussed at MARAC, and that obviously means that there's high risk domestic abuse in that particular household. So you do need to be aware of that. But usually there's some really good pieces of work that's done, you know, to support that victim, and also to work with the perpetrator in sometimes as well. And then lastly, MACE, so multi-agency criminal exploitation. This is where we discuss cases, not just children, but those up to the age of 25 that could be at risk of exploitation. So Jaden, who we just mentioned earlier on, would be a prime candidate to be discussed at MACE. And it's about looking at how we can prevent it escalating, and what kind of diversion things can we put in to get them away from that criminal space, get them back into education, get them into employment. You know, what are they interested in? Let's work with them, let's work with their family to maybe, you know, improve things for them so that they don't go down that road in the first place. So loads and loads of really positive things going on. Tabitha, do you want to talk about prevent and channel? I know you mentioned it briefly already, but
yeah, so Joe and I have been participating in this for years and years and years and years. It's been around for at least 10 years, if not 12. And yes, there are some, every now and then you see various groups pop up and say it does need reworking. There are currently 34 recommendations from a independent audit that was done a couple of years ago being processed by the Home Office. However, if you are concerned about somebody and that they may be being radicalised into an ideology, or it may be an unclear or an unstable ideology. So, for example, at one end, you might think about football hooliganism and extreme right wing, all the way through to, you know, those individuals that disagree with testing on animals and taking steps there. It's a really, really wide range of, but it depends on how they're demonstrating that and what action they're taking. So, you know, it's about, because obviously in the NHS we have a non-violent policy. However, you know, when you're listening to people, they can be angry, do not get me wrong, or expressing an emotion. But if they are expressing an emotion or statements about harming somebody else, then that is a reason to consider a discussion with the prevent team. And we have two very, very good officers here, one who's been around longer than I have, and you know, they are really happy to talk through cases. And if it turns out that your case is suitable for a referral, then they'll talk you through that. They are excellent. Okay. 50% of those individuals going through or identified as being at risk to radicalisation are predominantly young boys under the age of 18. Okay. So we know that the summer holidays are coming up, for example. And parents might say, oh, you know, you might be seeing somebody and they're saying, oh, you know, little Johnny, he's been stuck behind his computer all week. And you want to say, well, what's little Johnny doing up there? Do you know what he's doing? Might not be porn. It might be, you know, they're communicating with people on the dark web or not on the dark web who are taking advantage of them. It is still safeguarding. It is a form of exploitation. Okay, a couple of years ago, and it was in the BBC, so you can Google it. There were 2 young lads from the north of England, and one of them presented, or one of the parents presented at their GP surgery saying that they were concerned about their son. So, you know, it is something that happens. We have it happening in Suffolk. So, you know, it's in Essex as well as in Suffolk. There are prevent processes. So please, you know, if you're concerned, you know, you can reach out to Joe and I, and we'll put you in contact with the prevent police officers, and then you can talk it through with them, and they'll tell you what to do. One of the highest in the last year that's really raised is mixed or unstable, or oh, it's just gone from its MUU, mixed, unstable, and unspecified ideology. So what that means is that somebody may not, you know, they haven't decided where they're going to sit, or they're not sure, but perhaps 6 months down the line they've made a decision. So, you know, please, if you've got concerns about somebody, reach out to Joe and I, and we'll put you in contact with the appropriate police officers. But it's a very supportive system, and there are an awful lot of successes from it. An awful lot of successes. There we are. Thanks.
Lovely, thank you. It's good to sort of start ending on a positive, isn't it? I think.
Yeah.
So we do have a bit of time if anyone wants to discuss any cases or ask any extra questions or anything like that. Now is the time.
Don't all shout at once. Yeah. I mean, let's talk about safeguarding supervision. You know, please, if you aren't getting it, you know, let Sophie know. Sophie will come back to Joe and I. It's really important you get someone that you can talk to with your cases, because otherwise it's a lot to hold. You know, only in the news today there are, sadly, I don't remember if you remember, in Nottingham, a mother and her children were burnt. I think it was last year. And that person's about to go for sentencing. So, you know, there are horrible things that happen out there, and you know, it's important to talk about them. Yes, is that Val? Oh, you're on mute, my love. You're on mute.
I forget as well. I think this is probably I'm the only one that this applies to. What about those of us who are from organisations outside the NHS? I presume all the social prescribers belong to the NHS or have got access to System 1 anyway. But if an outside organisation like Citizens Advice or the local scout group, I suppose, makes a referral, they're doing it as a member of the public and presumably may never hear anything about it again. I mean, they're not going to be...
They should still hear. So actually they do it as part of their organisation, and they will definitely get the outcome sent to them, emailed to them. So as long as they've put all their details in there, their own contact details, they should get fully informed of the outcome. They should get calls. Yeah, it's exactly the same.
I mean, I don't think there is. You say exactly the same. I mean, but it's not going to come back to me as an individual because I'm only there 1 day a week. It's going to go back to a paid member of that organisation.
Okay, yeah. So it depends what. Yeah, I guess it depends what you've put down in your referral form. Yeah. But they wherever possible they will try and get it back to you. But yeah, if you're only there 1 day a week, it would be sensible to put a team email address in or something like that.
And linked with that, I mean, the social prescribers, that the Ipswich one is Connect for Health, which is they've certainly got access to System 1, but they're all employed, I think, by Citizens Advice. So I'm not totally sure. Again, I mean, you don't need to unpack all that, but whether they're in a position to make referrals as a health professional, as a professional.
So Citizens Advice, their safeguarding policy, I've actually read.
More than I have.
So they're the sort of things that come to us as designates. We get to see the policies and vet them and check that they're okay. So that's, one of the roles not that we hold and do. So just as a colleague here has just put from SNEE ICB, Julie, yes, Citizens Advice have their own safeguarding leads and their own processes. So they would, that referral would be done, but you would probably be linking in your safeguarding lead. I think the things that come in are when, so for example, Joe and I have cited 2 reasons why you wouldn't inform somebody. So let's say you go back to your safeguarding lead and they say, oh no, you must always talk to somebody. And we're going like, no, you need to cite very carefully what Joe and I have said. If it is prevent or if it is perplexing presentations, you need to make sure that they fully understand that that is our recommendation.
Yes.
Now, the chances of that happening are fairly slim, but, they're the really, otherwise, we read all of the policies. We get the safeguarding policies sent through for those people who have are taking on roles that are technically health. So, yeah, does that help?
Yeah, I think it just sets up another. But it's probably not the scope of here, but I mean, Citizens Advice, we heavily say to her, we wouldn't dream of referring you to anybody without your knowledge, permission. So that sets up a certain conflict. I mean, there we're saying I wouldn't tell the police, I wouldn't tell a solicitor, I wouldn't. So there's lots of different issues there. I mean, and again, I wasn't quite sure whether social prescribers came into this, because some of them are employed by other agencies, not the health service.
And that's where, but it's a if they're working with health, it's a health role. So that's why we get to see the contracts. That's why we get to see the policies. So if somebody says something that isn't in line with health, then we flag that.
And I think you have to be careful not to say we would never do referrals, we would never talk to anyone without your knowledge, because actually, you have a duty to refer safeguarding concerns and share information if it's for the safety and well-being of that particular person. So, you could add that onto the end, that we have to do it. If it's for your own safety, then we have to, something like that. Okay, anything else anybody wanted to raise? No. Okay, so this is just about keeping yourself up to date. So this is just a few ideas of how you can do that.
Jo, I think Sarah's got her hand up.
Okay,
yes,
sorry, I can't see. Sorry.
Yes, no, my fault, my error. I saw a hand and I thought it was Val's, so apologies.
Oh, thank you.
I haven't got rid of it, sorry.
No.
No.
Yeah, no, you had Val, sorry.
No,
so Sarah, yes. Sarah, is that you that's got your hand up? Sarah and Julie.
Sarah, yes, this is Julie, but Sarah, dip in when you want to. Just one of my questions is, I've done a couple of safeguarding referrals previously, and when the team have contacted those individuals, they've not wanted to progress it or move anything forward. And I'm just keen to know what happens, if anything, then as a result of that. So although I've had a discussion with the person that I'm going to refer to safeguarding and explain that's what I'm going to do, if that person then decides they don't want any support, what happens really?
Okay, so that is always dependent on the situation, and that's the biggest cop out in the world, isn't it? So sorry. So it really depends on does that person have capacity, what the referral is about. Oh, there's a whole raft of things that need unpicking. I mean, ultimately, if you're worried about something and you feel that it hasn't been given the due diligence, there is an escalation policy. Okay. But if somebody has had a telephone call, Julie, from somebody in the MASH, and they've spoken to that person and they've established that they don't think that there is anything to be concerned about, you would still get to hear about that. Sometimes just because they don't think it's met the threshold for a safeguarding investigation, which I should have said earlier, for adults is a section 42 and for children is a section 47, doesn't mean to say that other things won't happen. Okay. So it might mean that they, for example, it might be a housing referral, or they might be put in contact with the police for something, etc., etc. Does that so it doesn't just necessarily mean that safeguarding isn't happening, it could mean that something else is going to happen.
And just sorry, another question. I've only had feedback possibly from a very tiny percentage of referrals that I've made, either an outcome or just an update. Is that just something that started to happen recently? Because it only has been recently I've been getting that.
Is this in Suffolk? Is it
Yes.
Suffolk? Yeah, you should be getting an outcome. If you're the referrer, you should always get an outcome. So it may be that there's issues with staffing and they're very delayed. But what we would say is if you need to get that outcome, you can ring the MASH and say, I really need that outcome. And they should be able to share that with you over the phone. And equally, if you do get an outcome, but it doesn't tell you very much about what they've done, you can also go back to MASH and say, can you just give me a bit of information about how you made that decision and what you did within the MASH to be able to make that decision. So you can, they like to say that they've got an open door, you know, that they want people to be ringing in and liaising with them and things like that. So you should get an outcome. If you're the referrer yourself, you should always get the outcome directly. And if you don't, then please raise it. And if you have any trouble, let us know.
Lovely, thank you.
Yeah. And Sarah, oh, sorry.
Can you hear me?
Yes.
Yep.
Hey, it's working. My question was a bit mostly the same. Tara and I work together at our surgery, and we've got a couple of patients that we've referred for safeguarding a few times, and they both have capacity, but they're living in such terrible conditions. Is there nothing else that we can do? Because obviously Tara's our lead on care coordinator, and she does all the brilliant work for us. But it's frustrating for us when we know that these people need help, but they just constantly say, no, don't want it, yet their surroundings are dangerous to live in.
Okay, so apologies, there's an aeroplane going over my house. So what I'm going to ask is, there is a self-neglect and hoarding panel. Sarah, is that what you're worried about? That when you're talking about terrible conditions, is it the environment that person is living in?
It's the environment. They're not feeding themselves properly. They're not taking their medication correctly. They've got ulcerated legs. The nurses can't get in to dress them.
All right. So are you in Suffolk?
Essex.
Oh, right. Let me just look for the Essex version, and I'll put it in the chat. But they usually have self-neglect and hoard. The problem is they're always called something different.
Yeah.
I know what they are in Suffolk.
We're looking at a 90-odd-year-old. This particular person is a 90-odd-year-old man. Doesn't clean himself because he's got no running hot water. He doesn't have facilities for cooking. He's a massive hoarder. It's a fire risk. We've even had the fire people in to say that it's unsafe for him to live there. But
so then I'm a little bit surprised then that the fire service haven't done it, because they'll know about it. I'm just putting a link to a PDF for Essex, in the chat. My suggestion is you have a look at that. It's got all the guidance you need. It's got the pictures. And I always say with the hoarding, please, everybody, remember to write down the smell. Always write down the smells. It's a whole different conversation. So I put that in there. That came out December 2021, so it's probably still the current one, Sarah.
Okay, that's lovely.
No, that's a pleasure. That's a pleasure.
Thank you.
And all, as Tabitha's already said, always remember the escalation policy. So just if you don't agree with an outcome and you are still concerned, you can absolutely raise that as an issue and get it to be looked at again. And if you need to raise it higher, you can do, because they do make mistakes. So definitely do that.
Yeah, and remember the MCA slide. The last thing I said was not the last thing, I highlighted that there was a point at the bottom that was in the rainbow section, and it's called executive functioning. So people say somebody has capacity, but it's very well recognised that in extreme cases of hoarding, people do not have capacity. They are literally unable to change how they live. And there are very, very, very careful processes about moving that forward. All right. So I get really cross about, and Jo knows this because she's known me a long time, when people say, oh, they've got capacity. How do you know? Okay. How do you know?
I think for us in Essex is that actually a lot of people have been involved with this man. He's been in hospital. They've discharged him several times. They've been out, looked at his house, and they still let him go home.
And it is tricky, but I think it's about saying, have they done an executive functioning assessment of him? Okay. Just because he says, I know what to do, if it's not demonstrating any changes, it's highly unlikely he's unable to do that. Okay, but have a look at that PDF and just follow the steps through on that and see if that makes any changes.
Thank you.
No, it's a pleasure. Good luck. Good luck. Helen, I saw your name flash up, so that's the only reason I know.
Yeah, that's fine. Hi. So just following on from the hoarding side of things. So we deal with quite a fair few referrals for individuals who need intense deep cleans in order to be discharged from hospital. Would you say that obviously in order to let the carers go in and maintain the care package for however long they need it, would you suggest the safeguarding referral, or at least inquiries as to whether it's been raised? Would that be something that you think we should also include in our process, so to speak? Would that be something you'd say would be necessary?
So it's probably sensible, because can I just say, just because somebody's hoarding and demonstrating self-neglect doesn't necessarily mean that they have safeguarding issues. I realise the two are very, very interlinked, and if you're thinking about the Venn diagram, golly, they're overlapped. But just occasionally, it doesn't mean to say there are safeguarding, and that's why there's a separate process for it. You can absolutely ask and say, was a safeguarding referral considered? If so, does it need to happen? Blah, blah, blah. There's no reason why you can't ask that.
Okay, thank you. Thanks.
That's all right.
Okay. Anything else from anyone else? No. Okay. So on this slide, you've just got a few different examples of how you can keep yourselves up to date. So some of you will already have been aware of things like the e-learning that you can complete. You've also got access to things like the Suffolk CPD online. That is the Suffolk County Council run service that talks about multi-agency training. I'm pretty sure there's an Essex version as well. If you Google Essex CPD online, you can sign up for things like the NSPCC CASPAR updates and the Sky updates as well. So you literally put in your email address and then you'll get regular emails with research links and interesting reading and different training opportunities and things like that. Hopefully within your practice meetings you may be included in some of the case discussions, or maybe your safeguarding meetings as well. If you're not included and you know that you're involved in some of these cases, then please just ask to be included. I'm sure the other surgery staff won't mind you being involved in that, because you'll have really relevant things to add, but also it's important that you're kept in the loop with those cases as well. So basically it's just really important that you kind of reach out and access a wide range of different things, whether it's reading, whether it's multi-agency training, obviously coming to things like this, and keep a bit of a record of what you go to and what you learn from them, because that's really important evidence that you can put forward to be able to sort of demonstrate your learning and the different opportunities that you've had for training as well. And the last few slides really are, so we've obviously got our contact details there. That's how our team is made up. Any questions, which I'll come to in a second. And then the last few slides are lots of resources that you can access as well, useful ones. So some of them are Suffolk based, some of them are national, that it will be helpful for you. So I will stop sharing and see if there's any